So Nomsa and I are going to talk a little bit today about the harmonized cancer treatment guidelines for Sub-Saharan Africa. We're going to talk about why we're working to create these guidelines. We're going to review the process for them, and then we're going to talk a little bit about the impact. Okay, Nomsa. Okay, so the need for guidelines. This project first originated actually at a meeting of the World Cancer Congress in which a number of people happened to be in the room when we started discussing the need for harmonized cancer treatment guidelines for Sub-Saharan Africa. I think we have substantial evidence that patients who are treating according to standard treatment guidelines, have better outcomes than patients who are not. There have been a number of studies, both in the U.S. and in other countries, establishing survival rates for cancer patients. We're also starting to see in Sub-Saharan Africa the emergence of malpractice litigation, and as part of that, the need to document what is and is not an appropriate standard of care. And we're also starting to see the emergence of health insurance coverage in the region. And that emergence also requires us to be able to distinguish what is within a scope of practice and what is not, and what is a high level of care and what is not. So all of these have come together, I think, for several folks in the region to start to recognize the need to standardize the way that we treat cancer in Sub-Saharan Africa. So we started out really with a convenient sample of about 26 oncologists from a number of countries in Sub-Saharan Africa to figure out what kind of needs they had for cancer treatment guidelines. And a couple of the things that we found out, one is that more than 65% of the oncologists that we surveyed treat more than 10 types of cancer, which means that the information in guidelines needs to be something that can be accessed easily and quickly, and because they are having to master a lot of different cancer treatment guidelines at the same time. We also in the survey found that 54% of the people that we surveyed are using the NCCN guidelines. They're the most commonly used guidelines in Sub-Saharan Africa. NCCN is the National Comprehensive Cancer Network. It is an alliance of 28 cancer centers here in the U.S., and they make the cancer treatment guidelines that are most commonly used here in the U.S. So the African Cancer Coalition, as I mentioned, sort of came about because a number of people were in the room, kind of like Hamilton, I think, during this panel on cancer in Sub-Saharan Africa. That panel discussion was being led by the Honorable Minister Isaac Adewale from Nigeria, who brought up the issue of the need to standardize cancer treatment guidelines. And Dr. Jackson Orem, the director of Uganda Cancer Institute, was also there and expressed an interest in working together. I happened to be there, as well as the CEO of NCCN, and it was after that panel discussion that we started chatting about putting together the African Cancer Coalition. This was in 2016. Since then, the coalition has grown to more than 100 cancer experts from 13 countries in Sub-Saharan Africa, representing more than 30 cancer centers. The coalition meets twice a year, and what they do is they select a number of about 5 to 7 cancer types to focus on, and then we bring in cancer experts from different countries in Sub-Saharan Africa, as well as the chairperson of the guidelines committee at the NCCN. And then the American Cancer Society, the Clinton Health Access Initiative, and IBM Foundation all provide funding and logistics support for the meetings. So we have just finished up our 5th meeting earlier this month, and we will have our 6th meeting in August. And now I'm going to turn it over to Dr. Tskai to talk about this concept of resource integrated guidelines and how we've gone about harmonizing cancer treatment guidelines. Nomsa?
Thank you, Meg. So basically, these are what we call resource integrated guidelines, which aim to reflect the heterogeneity of resource availability across Africa. So we do appreciate the fact that different centers have different resources. You'd find from a rural center that is trying to administer chemo all the way to a comprehensive center that has both radiotherapy and more advanced imaging like PET scanning. So our principle basically is collectively we aspire to and will continue to advocate for the highest standard of care for our patients, reflecting up-to-date science and practice, We also recognize the imperative to expand access to effective, affordable care in settings where those standards are not yet attainable. So we came up with 3 levels of recommendations for the resource integrated guidelines. So we find that on the NCCN guidelines that we have adapted, what remains black text is generally available standard of care, which will not change even in the resource-constrained settings. What we grade out, the grey text, is where care may be costly or technically challenging and or have a lesser impact on oncologic outcome. So we came up to different consensus on that. And then we added a blue option. So with these options, we're saying these are regional options that may be considered when availability precludes general standard of care. So you find a lot of the blue options are actually treatments that were administered in the past and were effective before new research was done that has come up with more advanced treatments. So as an example here, I'll take you through prostate cancer. Okay, so on this is how it appears on the NCCN website or the site for Sub-Saharan African guidelines. So systemic therapy for metastatic castration recurrent prostate cancer. So everything that has remained in black is the standard recommendation from the parent guideline. We grade out from that parent guideline, you see the grey text, what we consider as advanced care that is not commonly available or beyond the reach of most patients in Sub-Saharan Africa. So examples, immunotherapy, which is not readily available, things like our newer drugs, abiraterone, enzalutamide, and also radium-223 treatments. Those we don't have available. Clinical trials generally for treatments, we do not have those available, trials using the new treatments. And then we added in blue things like bicalutamide, metronomic cyclophosphamide, which are things that were used in the past some 10, 20 years ago and were effective. Here we're just adding this on to show even the centers that are not advanced that they can utilize some of the old treatments and still have a response instead of actually turning the patient away because there are no options. Another example is breast cancer. So what remains in black is generally acceptable and we have available. What we've grayed out, things like HER2, new status, we don't have available. And if you find in a center where it is available, we do not have Herceptin available. It's costing anything between $1,500 US to $3,000 in certain settings. So that's not generally available per session. And then genetic counseling also, we don't have access to BRCA testing in most of the centers in Sub-Saharan Africa and MRI. So we added in blue, added options, chest X-ray and ultrasound scan. And also some people may be stuck where HER2 is unavailable as the algorithm will direct to HER2 is positive or negative. So if HER2 status is unknown, so we've added one should follow, we've got an asterisk here, should follow the negative path so that one who's following this algorithm is not lost. And also a bit of advice where genetic counseling is not available, that patient and family discussion just to find out the family history can be done. So the guidelines that we've done so far, about 25 guidelines, which cover 88% of incident cancers in Sub-Saharan Africa. So that's majority of the cancers have been covered. So all the way from supportive care, that's your palliative care, pain control, anti-emesis, head and neck cancers we've covered, lung cancers we've covered, gastrointestinal cancers, gynecological malignancies, and genitourinary malignancies have been covered. So this page is just showing what it appears. There is an app available, an NCCN app, so these guidelines are also available. So you'd find specifically for the Sub-Saharan Africa, the cancer is written plus an addition that says Sub-Saharan Africa. So we've adopted in May 2019 recently. These are yet to be released. Adolescent and young adult oncology, anal, brain, the central nervous system, the remaining head and neck cancers, Hodgkin's lymphomas, soft tissue bone sarcomas, neuroendocrine. And we're looking forward to meeting in August 2019 to do the remaining malignancies, ALL, AML, occult primary, the management of that, thyroid cancers, thyroid tumors and malignancies, penile and testis vulvar cancers. So with that, we would have covered approximately 98% of estimated cancer incidence in Sub-Saharan Africa, which is quite significant. Thank you, Meg.
Sure. Thank you, Nomsa. So now that we have these adaptations, I think some of the things that we're looking for are looking at the impact these guidelines will have. One of them obviously is just to give better guidance to our clinicians so that they're not having to adapt on their own and so that the things they do are backed up by guidelines. So we're trying to give as much options as possible and also to reflect the fact that we have such a wide range of resource availability, but we want all of that to be reflected in one guideline. So these guidelines should guide decision makers, also about communicating with policymakers about what kind of resources should be available. So there's a reason why some of the advanced recommendations, we colored them gray, but we didn't remove them. And that's because we're not giving up on having them. They are gray to indicate that if you don't have them, it is not an excuse to withdraw treatment or withhold treatment, so you can treat without them. But we're leaving them on there as a reminder that these are part of high-quality cancer care, and they should be available in cancer centers. We're also developing accompanying guidance for policymakers that actually breaks down which resources we consider to be essential and which ones we consider to be advanced, so that they can start planning resource allocations appropriately. I think another exciting thing about these guidelines is that they finally give us an opportunity to start establishing collaborations around training and research. So we've already started to see some exchanges among members of the coalition. People are moving across countries to help set up new radiotherapy machines, train new teams, and we're starting to develop new research collaborations around these cancer areas. And then finally, we hope that this is useful in encouraging multidisciplinary coordinated care for cancer. So far, the harmonized guidelines have been endorsed by the government of Ethiopia, government of Nigeria, and Ocean Road Cancer Institute in Tanzania. So together, these three countries are about 30% of the cancer incidence in sub-Saharan Africa. We hope to get some more endorsements over the next year as more countries have an opportunity to review these harmonized guidelines and look at how to incorporate them in their national cancer control plans. And then if you are at the Aortic Conference in Maputo in November, please stop by and see us. We will be having a session on the guidelines. We will also be doing a lot of programming around a booth about the guidelines and also having a tablet set up for people to take a look at them and talking about some of the activities that we're doing to drive uptake of the guidelines. All right. Thank you very much. Thank you, Nomsa.
Thank you, Meg. Thank you, everyone.